Okay, let me get it. Okay. All right. Good morning, everybody. Welcome to Caregiving Cafe. Today, Dura Sims from True Heart Hospice and I, Lynn Greenblatt, it's still the same, have the pleasure of having Ashley Olsen and Horacio Huerta, who are going to talk to us about Medicare Made Clear. It seems to me that no matter how much you know about Medicare, there's always something else. And of course, there are yearly updates. So it's always a good idea for all family caregivers and families to stay updated about those changes or to be reminded of certain benefits and supports that Medicare offers. So without further ado, I will turn it over to Ashley Olsen, who is also with UnitedHealthcare, and take it away. And again, thank you both for being here today.
Well, I guess the first thing you need to know about Medicare is to find out if you're eligible. So I've got a presentation here that starts right at that first step. Medicare is a federal program that offers health insurance to American citizens and other eligible individuals based on age, disability, or a qualifying medical condition. Medicare is individual insurance and does not cover spouses or dependents. To be eligible for Medicare, you must be a US citizen or legal resident. Legal residents must live in the US for at least 5 years in a row, including the 5 years just before applying for Medicare. And you must meet one of these requirements. You're age 65 or older, you're younger than 65 with a qualifying disability, or you are any age with a diagnosis of end-stage renal disease or ALS. When it's time to enroll, you should be automatically enrolled in Medicare Part A and Part B if you are receiving Social Security or Railroad retirement benefits when you become eligible. You'll receive your Medicare card in the mail. You need to enroll in Medicare yourself if you are not receiving Social Security benefits when you become eligible. To do that, go to ssa.gov/benefits/Medicare to enroll online, or call or visit your local Social Security office. Medicare is not Medicaid. Both Medicare and Medicaid are government programs. Both programs help people pay for healthcare, but that's where the similarities end. Medicare is generally for people who are older or disabled. Medicaid is for people with limited income and resources. Medicare is governed by the federal government. Medicaid programs are governed by individual states. Are you turning 65? You're eligible for Medicare at age 65. You have a 7-month initial enrollment period called IEP for Medicare. It includes the month you turn 65, the 3 months before, and the 3 months after. It begins and ends a month earlier if your birthday is the first day of the month. Sign up early. Coverage begins the first day of your 65th birthday month if your enrollment is completed during the first 3 months of your IEP. It begins the month before if your birthday is on the 1st. Your coverage start date may be delayed if you sign up later. You have choices. You may enroll in Medicare Part A, Part B, or both. You may also add additional coverage, such as a Medicare Advantage Part D or Medigap plan. Are you working past 65? You still have an initial enrollment period. You have Medicare decisions to make at age 65, even if you have coverage through an employer plan, yours or your working spouse's. Your IEP happens when you turn 65, whether you continue to work or not. Depending on the employer coverage you have, you may be able to delay enrolling in Medicare without penalty. Talk with your employer's benefits administrator to understand your options and determine if your coverage is considered creditable. You may be able to delay enrollment if your employer has 20 or more employees, the employer provided health insurance is considered creditable, or the employer doesn't require covered spouses to enroll in Medicare at age 65 in order to remain on the employer's plan. Pay attention to details. You must stop contributing to a health savings account, HSA, once you enroll in Part A or Part B. Also, get a notice of creditable drug coverage from your plan administrator. You must have this documentation to avoid the Part D penalty if you plan to delay enrollment. If you have a disability or medical condition, you will be automatically enrolled in Medicare Parts A and B after your 24th month of disability. You will still have a 7-month IEP. Enrollment timing for people with ESRD or ALS is based on the time of diagnosis and other factors. Now let's look at your main coverage choices. You can stick with original Medicare, or you can get more coverage. Original Medicare Part A and B helps pay for doctor visits and hospital stays, but it does not cover everything. Many people choose additional coverage by enrolling in one or more private Medicare or Medicare-related plans, including Part D or prescription drug plans. Medicare prescription drug plans help pay for medications prescribed by a doctor or other healthcare professional. Medicare supplement insurance plans. Medicare supplement insurance plans, or Medigap plans, help pay some of the out-of-pocket costs not paid by original Medicare. And finally, Medicare Advantage plans, or Part C plans. Part C plans combine Part A, B, and often prescription drug coverage, Part D. Some plans may offer additional benefits like coverage for routine vision and dental care. So, step one, first you need to enroll in original Medicare provided by the federal government. Part A helps pay for hospital stays and inpatient care. Part B helps pay for doctor visits and outpatient care. Now you've done that, you can look at additional coverage options that are offered by private insurance companies. Option one is this Medicare Part D plan that helps pay for prescription drugs. You can also add Medicare supplement insurance, the Medigap, that helps pay some out-of-pocket costs. Option two is the Medicare Advantage plan, or Part C. Remember, this combines original Medicare Part A and Part B coverage in one plan and usually includes prescription drug coverage as well. Be sure to consider all of your costs. Medicare isn't free. The amount you'll pay depends on the coverage you choose and the healthcare services you receive. Costs you may pay with Medicare is your premium. Medicare Part B has a monthly premium. Some people also pay a premium for Medicare Part A. Medicare Advantage Part C and Part D plans may also have premiums, and amounts will vary by provider and plan. The deductible is a set amount you pay for covered services before your plan pays. For example, a $500 deductible, you pay up to $500 and the plan pays the rest. There is copay, a fixed amount that you pay at the time you received a covered service. If it was a $20 copay, you would pay $20 and the plan pays the rest. Another way is co-insurance. That's a percentage of the cost of the covered service is what you pay. So you would pay 20% if that was the co-insurance, and the plan would pay the rest. You can find out if you qualify for financial help. Many people assume they don't qualify for help and they never look into it. Don't make that mistake. If you have a low income and few assets, you may qualify for help through one or more of the following programs. Medicaid. Medicaid provides health coverage for people and families with limited incomes. It may also offer some services not covered by Medicare. Each state creates its own program, so contact your state Medicaid office for more information. If you qualify for both Medicare and Medicaid, you are called dual eligible. In this case, you keep your Medicaid benefits and may get additional benefits from Medicare. The two programs can work together to cover most of your healthcare costs. There's an extra help program. This helps pay some or all Part D premiums, deductibles, and copays. There's a Medicare Savings Program. Medicare Savings Programs help pay some or all Part A and Part B premiums, deductibles, and coinsurance. Also, you automatically qualify for extra help program if you qualify for the Medicare Savings Program. Program of All-Inclusive Care for the Elderly, or PACE. PACE combines medical, social, and long-term care services for frail elderly people who live in the community but not in a nursing home. This program is not available in all states. Let's see. Okay, Medicare Part A. Part A covers hospital stays and most of the inpatient services. Coverage includes a semi-private room, your hospital meals, skilled nursing services, care and special units such as intensive care, drugs, medical supplies, and medical equipment used during an inpatient stay, labs, x-rays, and medical equipment as an inpatient, operating room and recovery room services, some blood transfusions in a hospital or skilled nursing facility, inpatient or outpatient rehabilitation services after a qualified patient stay, part-time skilled care for the homebound after a qualified inpatient stay, hospice care for the terminally ill, including medications to manage symptoms and control pain. The cost of Part A. The premium is $0 per month if you or your spouse made payroll contributions to Social Security for at least 10 years, 40 quarters. Otherwise, your premium could be up to $4.99 a month. And your premium may be higher if you don't sign up for Medicare when you are first eligible. The deductible is $1,556. That's $1,556 per benefit period. A benefit period begins the day you are admitted to the hospital and ends when you've been out of the hospital 60 days in a row. Coinsurance. Home hospice patients may pay a small coinsurance amount for inpatient respite care or durable medical equipment used at home. Plus copays for hospital stays, $0 for days 0 through 60, $389 per day for days 61 through 90, $778 per day for days 91 and beyond. You have 60 lifetime reserve days of coverage you can use if you're in the hospital longer than 90 days. Each lifetime reserve may be used only once, but you may apply the days to different benefit periods. Lifetime reserve days may not be used to extend coverage in a skilled nursing facility. The copays for skilled nursing facility is $0 for days 1 through 20, and then $194.50 per day for days 21 through 100. For hospice care, copays during home hospice may include up to $5 per prescription for pain and symptom management. That's Part A. Now, Part B. Part B covers care at a clinic or at a hospital as an outpatient. Coverage includes doctor visits, including in the hospital, annual wellness visit, ambulatory surgery center services, ambulance and emergency room services, skilled nursing services, preventative services like flu shots or mammograms, clinical laboratory services like blood and urine tests, x-rays, MRIs, CAT scans, EKGs, and some other diagnostic tests. Some health programs like smoking cessation, obesity counseling, and cardiac rehab. Physical therapy, occupational therapy, and speech language pathology services, diabetes screening, diabetes education, and certain diabetes supplies, mental health care, durable medical equipment for use at home, like wheelchairs and walkers. Some services may have limitations. Preventative services and screenings are covered on set schedules, such as a yearly flu shot. Other covered services and supplies must be medically necessary to diagnose or treat a disease or condition. Now, Part B costs. The premium is between $170.10 and $578.30 each month. Part B has a monthly premium that is either deducted from your monthly Social Security benefits check or that you pay directly to Medicare. The amount you can pay can vary depending on your tax reported income from 2 years prior. Monthly Part B premium costs range from $170.10 to $578.30. You'll pay the standard amount if you enroll for the first time in 2022, you are not receiving Social Security benefits, your premiums are billed directly to you, you have Medicare and Medicaid, and Medicaid pays your premium. You may pay less if you enrolled in Part B in 2021 or earlier, and your premium payments are deducted from your Social Security check. You may pay more if you'll pay an income-related monthly adjustment amount if your reported income from 2020 was above $91,000 for individuals or $182,000 for couples. The deductible is $233 per year. Coinsurance is 20% of covered services. You generally pay 20% of the Medicare approved amount for the covered services you use with no annual out-of-pocket maximum. Medicare pays the remaining 80%. The Medicare approved amount is the amount Medicare decides providers should be paid for covered services. Doctors and other providers may accept assignment and take the Medicare approved amount as payment in full, even if it's less than what they usually charge. Doctors who do not accept assignment may charge more than the Medicare approved amount and bill you for the difference. The additional amount they may bill is called the limiting charge. The provider can only charge you up to 15% over the amount that non-participating providers are paid. Non-participating providers are paid 95% of the fee schedule amount. The limiting charge applies only to certain Medicare covered services and doesn't apply to some supplies and durable equipment. Enroll in Original Medicare Part A and B on time to avoid late enrollment penalties. The Part A late enrollment penalty, it's 10% of the premium. If you must pay a Part A premium and enroll late, you could pay a penalty. The late enrollment penalty is 10% of the premium. You pay the penalty in addition to your premium for twice the number of years you delay enrollment. For example, if you delayed enrollment for 2 years, you will pay an additional 10% of the Part A premium for 4 years.
Why?
Yeah. For Part B late enrollment penalty, 10% of the premium. The Part B penalty is 10% of the monthly premium amount for each full 12-month period enrollment is delayed. You pay the penalty in addition to your premium for as long as you have Medicare Part B. For example, if you delayed enrollment for 3 years, you will pay an additional 30% of the Part B premium as long as you have Part B. So 10% times 3 years of delay equals 30% total penalty. So those are significant increases. So just bear that in mind. Wow. Original Medicare Parts A and B doesn't cover everything like these benefits. Most care out of the United States, personal expenses while hospitalized, custodial care, long-term care, days spent in a psychiatric hospital beyond certain set limits, hospital days beyond set limits, eye exams, eyeglasses or contact lenses, hearing exams, hearing aids, routine dental care, dental exams, cleanings, and x-rays, most prescription drugs, and wellness benefits such as gym memberships. Here's where Medicare Part C comes into play. Medicare Advantage plans, or Part C, combine Part A and B benefits. In addition to Part A and B benefits, many plans also offer Part D prescription drug coverage, hearing exams or hearing aids, routine dental care, eye exams, eyeglasses, or contact lenses, wellness benefits such as gym memberships. Benefits may vary by plan and could include other extra benefits such as transportation to medical appointments or virtual visits. Medicare Advantage plans are often premium free. You will continue to pay your Part D premium directly to Medicare and your Part A premium too if you have one. Some plans may charge premiums, deductibles, copays, or coinsurance. Plan premiums can change each year. Copay amounts may vary based on the covered item or service. Deductibles may be applied to drug benefits and not medical benefits when a plan covers both. Coinsurance may apply for some services. Where you get care can affect your costs. Many Medicare Advantage plans are coordinated care plans and contract with a network of doctors and hospitals. Some plans may require you to choose a primary care provider from their network, and each plan creates its own network. Certain types of plans may allow for more freedom in choosing providers, but costs could vary based on the selected provider. Costs for providers and services can vary if they are considered in-network versus out-of-network. In most cases, you pay less for care received from in-network providers than for providers outside the network. All plans are required to offer nationwide coverage for emergency care, urgent care, and renal dialysis. To understand the out-of-pocket maximum, Medicare Advantage plans are required to set an out-of-pocket maximum, which is the total amount you may pay for Part A and Part B services covered during that plan period, usually a calendar year. The goal of the out-of-pocket maximum is to help provide some financial protection for out-of-pocket costs. Original Medicare doesn't offer an out-of-pocket maximum. Plans can have different out-of-pocket maximums as long as the amount doesn't exceed the year's out-of-pocket maximum limit that is set by Medicare. This limit can change each year. For 2022, it is $7,550. If you reach the out-of-pocket maximum, your plan will then pay for all of your covered costs for the remainder of the plan period. It's important to understand the following costs do not count toward the out-of-pocket maximum. That is premium payments, drug costs, and costs of extra health services such as vision or dental. Medicare Advantage coverage and costs will vary from plan to plan and by location and plan provider. Health maintenance organizations, or HMOs. These require you to seek care from providers in your network and choose a primary care provider who may then manage any care you receive from specialists. It does not cover any of the extra costs for care outside of the plan's network, except for emergency care, urgent care, and renal dialysis. Referrals may or may not be required to get specialty services. Then there are point of service plans, or POS. This is a type of HMO plan that lets you see doctors and hospitals outside the plan network for some covered services. Out-of-network care may result in higher copays or coinsurance, and you may or may not be able to get a referral for specialty services. Preferred provider organization plans, or PPO. This has a provider network you can use, but also offers more freedom to choose doctors and other providers outside the plan network for all covered services. Out-of-network care may result in higher copays or coinsurance, but this plan does not require you to get a referral for specialty services. Medicare Advantage plans operate within defined geographic areas called service areas. You must live in a plan's service area to become a member. You may have the following plans to choose from. Private fee-for-service plans. This is provider choice. Typically, you may see any provider in the United States who accepts Medicare and the plan's payment terms and conditions. The plan design varies in their coverage and costs, but you are not required to get a referral for specialty services. There are special needs plans. These are designed for people with specific healthcare needs and usually have plan-specific eligibility requirements. Dual eligible special needs plans, or DSNAPs, for people who have both Medicare and Medicaid. There are chronic special needs plans, or CSNAPs, for people living with qualifying chronic conditions. There are institutional special needs plans for people who live in a contracted skilled nursing facility. There are institutional equivalent special needs plans for people who live in a contracted assisted living facility and need the same kind of care as those who live in a skilled nursing facility. Extra care may be provided by care managers or nurse practitioners to help members get the care they need. There are medical savings account plans. These combine a high deductible health plan with a special savings account. Funds received from Medicare are deposited into the savings account and may be withdrawn tax-free to pay for qualified healthcare expenses. These do not include prescription drug coverage. Medicare Part D. Medicare Part D provides coverage for prescriptions and some vaccines. Coverage includes drugs most commonly prescribed for Medicare beneficiaries as determined by federal standards, specific brand name drugs, and generic drugs included in the plan's formulary. Commercially available vaccines that are not covered by Part B. Part D plans typically do not cover drugs that are not on the plan's formulary, drugs prescribed for anorexia, weight loss, or weight gain, prescriptions for fertility, erectile dysfunction, or cosmetic purposes, prescription vitamin minerals, and non-prescription drugs or over-the-counter meds. You can get prescription drug coverage through a private insurance company in two ways: a standalone Part D plan or with a Medicare Advantage plan that includes prescription drug coverage. The following pages will cover what you need to consider when choosing a Part D plan, such as costs vary by the plan and provider. Each plan has its own formulary, drug list. Some plans have network pharmacy, and your costs can vary by the drug stage you are in. You must live in the service area of the Part D or Medicare Advantage plan to enroll. You can find explanations on specific drug costs in each Part D plan's summary of benefits or evidence of coverage materials. Part D plans vary by the plan and provider you choose. Each plan negotiates prices with drug manufacturers and pharmacies. Your copays and coinsurance rates are based on these prices and on guidelines set by Medicare. Review the plan's formulary to see if your drugs are covered. A formulary is a list of prescription drugs covered by a plan. Medicare sets standards for those types of drugs Part D plans must cover, but each plan chooses the specific brand name and generic drugs to include on its formulary. Plans may add or remove specific drugs from their drug list from year to year. Changes may be made during the year under certain circumstances, such as if a drug is removed from the market. You will be notified by your plan provider when changes happen if it affects a drug you're taking. Your total prescription drug costs will also be impacted by the number of prescriptions you take, how often you take them, if you get them from an in-network or out-of-network pharmacy, and what Part D coverage stage you are in. Your drug costs can vary by the plan's drug tiers. In general, drugs on low tiers cost less than drugs on high tiers. Additionally, plans may charge a deductible for certain drug tiers and not for others, or the deductible amount may differ based on the tier. In addition to tiers, plans may also require step therapy for certain drugs. With step therapy, you must first try a low-cost drug that's been shown to be effective in treating your condition before the plan will cover a more expensive drug. If the low-cost drug doesn't work, then you and your doctor can request approval from the plan to try the next level treatment. During the year, you may go through different drug coverage stages. There are 4 stages, and it's important to understand how each one impacts your prescription drug costs. You may not go through all the stages. People who take few prescription drugs may remain in the annual deductible stage or move only to the initial coverage stage. People with many or high cost medications may move into the coverage gap and/or catastrophic stage. The coverage stage cycle starts over at the beginning of each plan year, usually on January 1st. So there's the annual deductible stage. You pay for your drugs until you reach your plan's deductible. If your plan doesn't have a deductible, your coverage starts with the first prescription you fill. The initial coverage stage. You pay a copay or coinsurance, and your plan pays the rest. You stay in this stage until your total drug costs reach $4,430 in 2022. Then we have the coverage gap, or the donut hole. You pay 25% of the cost for both brand name and generic drugs in 2022. You stay in this stage until your total out-of-pocket costs reach $7,050 in 2022. And then the catastrophic coverage stage. You pay a small copay or coinsurance amount, and you'll stay in this plan for the rest of the plan year. The coverage gap or donut hole opens when you and your plan have paid up to a certain limit for your drugs in 1 year. When you're in this stage, you pay a bigger share of the cost for your prescriptions than before. You will exit the coverage gap only when the total amount you and others on your behalf have paid for your drugs reaches another set limit. The limits to enter and exit the coverage gap are set by Medicare, as well as what counts toward reaching the limits, and both can change each year. If you get extra help from Medicare, the coverage gap doesn't apply to you. Extra Help is a program for people with limited income, those who need help paying Part D premiums, deductibles, and copays. To see if you qualify for Extra Help, you can call Medicare at 1-800-MEDICARE, 24 hours a day, 7 days a week, or you can call the Social Security Administration at 1-800-772-1213. So what are the total drug costs? That is the amount you or others on your behalf and your plan pay for your covered prescription drugs. Your plan premium payments are not included in this amount. What are your out-of-pocket costs? The amount you or others on behalf pay for your covered prescription drugs, plus the amount of the discount that drug manufacturers provide on brand name drugs when you're in the third coverage stage, the coverage gap or donut hole. Your plan premiums are not included in this amount. Now, the Part D late enrollment penalty is 1% of the premium. The Part D penalty is an additional 1% of the average Part D premium for each month you delayed enrollment. You pay the penalty every month for as long as you have prescription drug coverage. For example, if you delayed enrollment for 18 months, you will pay an additional 1% of the Part D premium. That's 18 months of delay times 1% is an 18% monthly penalty. You may have to pay a Part D late enrollment penalty if either of the following are true. You didn't enroll in prescription drug coverage when initially eligible for Medicare and didn't have other credible drug coverage to qualify for enrollment during a special enrollment period. Or you didn't enroll in prescription drug coverage within 63 days of losing your creditable drug coverage, usually from an employer's health plan. So Medigap. Medicare supplement insurance or Medigap plans can help pay some of the out-of-pocket costs not paid by Parts A and B. Plans are offered by private insurance companies but are standardized by the federal government. All include full or partial coverage for Part A hospital coinsurance, Part B coinsurance or copays, cost of blood transfusions for the first 3 pints, costs for 365 extra hospital days, hospice care coinsurance. Some may also help pay for your Part A deductible, Part B deductible, foreign travel emergency care up to the plan limits, and Part A skilled nursing facility care coinsurance. Medigap plans set their own premium costs. As a general rule, the more generous the coverage, the higher the premium. Premiums will also vary by provider, even if the plan letter is the same, and premium amounts can change from year to year. Different plans pay different costs. The level of coverage and what you will pay varies by plan. Some plans split certain costs with you up to a set limit. Others leave certain costs for you to pay on your own. Some Medigap insurers offer value-added services. These services may come from the insurer or other companies. Some things that are offered may include discounts on vision, hearing, or dental service, 24-hour nurse phone lines, and free or discounted gym memberships. Medigap plans are offered by private insurance companies, but they are standardized by the federal government. Each plan is labeled with a letter, and all plans with the same letter offer the same basic benefits nationwide. Benefits covered by a chosen Medigap plan. Part A hospital coinsurance and 365 extra hospital days. Part A deductible. Part B coinsurance or copays. Part B annual deductible. Part B excess charges. Cost of blood transfusions up to 3 pints. foreign travel emergency up to plan limits, hospice care coinsurance cost, Part B preventative care coinsurance, skilled nursing facility care coinsurance, yearly out-of-pocket limits before benefits paid at 100%. Is Medicare Advantage or Medigap right for you? Many people ask the question, should I get an Advantage plan or a Medicare supplement plan? Both are offered by private insurance companies, and with either choice, you continue to pay your monthly Part B premium to Medicare. The main things to think about when you're deciding which is right for you are you comfortable choosing a healthcare provider from within a provider network, or do you want to be able to choose any provider that accepts Medicare patients? Would you rather have prescription drug coverage included in one plan or buy a separate Part D prescription drug plan? And would you rather pay a low or $0 monthly premium and copays for services as you use them, or pay more in monthly premiums and have lower out-of-pocket costs for services you receive? Okay. You have many options when it comes to your Medicare coverage. Answering these questions can help you feel more confident when shopping for a Medicare plan. 1, generally, how often do you visit the doctor? 2, what prescription medications do you take and how often? 3, do you have any major health conditions that you need special care for? 4, what did you pay out of pocket for health care in the last 12 months? 5, do you want coverage for dental, vision, hearing care services or items? And 6, do you need help paying for Medicare? Here is an overview of the different times you can enroll. For those who become eligible due to age, it includes your 65th birthday month, the 3 months before, and the 3 months after. Your IEP begins and ends 1 month earlier if your birthday is on the 1st of the month. If you're eligible due to a disability, your 7-month IEP includes the month you receive your 25th disability check, the 3 months before and 3 months after. The GEP, the general enrollment period, is for those who did not sign up around their 65th birthday. You can enroll in Medicare Part A, Part B, or both. The GEP happens every year from January 1st to March 31st, with coverage beginning July 1st. You may enroll in a Medicare Advantage plan or a prescription drug plan from April 1st to June 30th the same year. SEP, Medicare provides a special enrollment period for enrolling after retiring or losing your employer coverage. If you plan to work past 65 or have employer health coverage through a spouse, you have options. If an employer has 20 or more employees, generally you can choose to delay enrollment and drop your employer coverage for Medicare, or have both Medicare and employer coverage. If an employer has fewer than 20 employees, generally you will need to enroll in Medicare during your initial enrollment period. If you have health coverage through a spouse's employer, you may be able to delay, or you may need to enroll at age 65, depending on the employer. You need to have creditable drug coverage to qualify to delay. Creditable drug coverage means the employer drug coverage is at least as good as the standard Medicare Part D plan coverage. Without this, you could face penalties for Part D if you enroll after your IEP is over. If you qualify to delay enrolling in Medicare, there are still some important things to understand. You can choose to delay Part A, Part B, or both. Some people choose to get Part A at 65 because it's usually premium free for most people. If you have a health savings account, be aware that once you enroll in any part of Medicare, you can't continue to make contributions to your HSA. You will need to provide written proof of your credible drug coverage from your employer to avoid Part D penalties. You do not need to provide notice that you will delay enrolling unless you're already receiving Social Security or Railroad Retirement Board benefits. You can delay without penalty as long as you enroll within 8 months of either losing your or your spouse's employer coverage. SEP, Medicare also provides special enrollment period for life qualifying events. Events may include moving, leaving retiree, union, or COBRA coverage. The special enrollment period is 3 months.
And then
AEP,
right there, Ashley. Yeah, I think this will be the last slide on that, because the rest would be like a calendar. So we can go ahead and finalize on that one.
okay, tell you
Yeah.
about AEP and close it up.
Yeah, on the AEP.
AEP. So during the Medicare annual enrollment period, you can join, switch, or drop a Medicare Advantage or Part D prescription drug plan and apply for Medicare supplement insurance. You'll automatically go back to original Medicare if you drop a Medicare Advantage plan, and you will lose drug coverage if it was included in your plan. You may replace it with a standalone Part D prescription drug plan at this time without penalty. A penalty may apply if you drop coverage and decide to get it again later. You can also apply for a Medicare supplement insurance plan if you revert to original Medicare during the annual enrollment period or later. But remember that all of your pre-existing health conditions can keep you from being accepted into the plan or may result in a higher premium. The AEP is from October 15th until December 7th.
Thank you.
It's a mouthful, huh? There's a lot of
Yeah.
information. I thought I could read faster, but we
But
didn't.
no, but you know what? This is why we need somebody to talk to us, because it's not simple.
Yeah.
You know, or the parts themselves. I mean, there's just so many parts, or if this, or qualifiers and things. So that's why it's good to have this, and it's also great that it's being recorded. So we can go back and
Right, you
address,
can hit
know,
pause.
so, yeah. So anyway, so thank you for that. And I don't know if Horacio wanted to add anything to that, or bring up a
Yes, absolutely. Just if I'm able to share, I don't know if they allow me to share my screen. I like to kind of go over a real quick overview for caregivers and their options that they have. I'd like to kind of show them that through UnitedHealthcare.
Well done. Working on the technical screen sharing.
I know, I'm
Task.
Okay, there we go. Got it. Yeah, and thank you for I want to thank you guys for allowing us to come in and share, and it's a representative like Ashley that comes in, and she would be the what we call the Medicare expert, where she comes in and kind of talks more about the detail, because everybody on the call is different. We're different. Everybody has a different background in regards to their income levels and Social Security and et cetera. And that's where we would have like representative like Ashley comes in, sits down, goes over the plan, goes over the physician, the medications, the things that they need to take in regards to the offering between Medicare, traditional Medicare, and then of course the Medicare Part C, as she talked. Right now, if y'all can see my screen, so yeah, is that good? Can you see that? Okay. And it's just real quick. These are quick tips, pretty much that you all probably have discussed and worked with, in regards to caregiving, and I do want to say that caregiving, it comes from the heart, because I think it's all about love, and my hats off to each and every single one of you. Right now going through the same situation with my father-in-law, and it's a tough situation sometimes, because there's daily activity going on in our own lives, and in the caregivers as well. But these are real quick tips that UnitedHealthcare has, and I'm going to share the links. That way I can go ahead and give you all the links, so that way the people that log on with you all can have those links through aids that UnitedHealthcare gives. But I wanted to share this here, and something interesting is that 1 in every 5 adults are caregivers, and these can be spouses, these can be children, can be the oldest daughter, youngest daughter, whichever the case is. But 20 hours a week are spent on an average caring for family members, an unpaid caregiver, and that's just minimum 20 hours. I mean, sometimes it's 24/7, where that comes in. These are the things that I want you to see in regards to lifestyle tips. First, it's accept the help, and that's very important for the people that are on the call today. Is accepting the help that is around you, and that's very important. It could be from home health, it could be from a nurse, or it could be from your own physician. just simply just as Ashley coming on, just kind of, getting you a little bit more information of, where to save money and where to, have that opportunity to maybe qualify for additional benefits. Be prepared with a list of ways that others can help you, and let others helpers choose that, what he or she would like to do. Get that assistance, get that help. Sometimes we say, no, I have it, I got it. But sometimes, we just got to say, I need help. Two, focus on what you are able to provide. It's normal to feel guilty sometimes, but understand that no one is perfect as a caregiver. It's very important. Just need help. Number one. Two, okay, let's focus on what I really need. Maybe we need transportation. Maybe we need transportation going to the doctor's office. Maybe I need help with the transportation coming in and helping me, getting my family member, that can take us on a specific transportation to the doctor's office. I don't want to drive, or whatever the case is. Those are things that we can always just be honest with yourself, be transparent, and then of course focus on what your needs are and accept the help. Number three, set realistic goals. Break large tasks into smaller steps that you need to do one step at a time. Maybe just focus on caregiving. Sometimes we think about, oh my God, who's going to cut the lawn, or who's going to come in and fix a leaky sink, or whatever the case is. That's where accepting help is, and programs. Just real quickly, UnitedHealthcare has programs internally for members through UnitedHealthcare that for example, there's a benefit that we have. It's called house calls. House calls comes in once every 6 months, and they come in and do a 1 hour doctor talk. They're in your home, and there's a nurse practitioner that goes to the house, sits down, goes over the whole medical part of it. But then again, not only are they looking at the medical component, they're also looking at the social services component. Maybe they realize that there's a leak in the roof, or they see that it's they have no electricity, or they need assistance with paying utility bills on and so forth. That's where those individuals come in and through UnitedHealthcare and assist and help that. And the last tip there is join a support group. And I hats off to both of you ladies that are in charge of this group. It's amazing, of this support group. I'm pretty sure we've been here for you. You have multiple of other organizations that come in and give you tips and information how to make it easier, and how to make it easier for the families and of course for the patients. Additional resources, and again, I'm going to send you this brochure. I do have more information that I'd love to share, but it would take more time to be on it. But again, it's additional resources. It's through uhcforcaregivers.com. That's one of the links that I'm going to give you all. And this is, and I already have it open, so I'll log into that real quickly. The second resource that y'all can have, it's through the AARP, the American Association of Retired People. It's that card that you get when you're 50 years old that you say, oh my God, I don't want to see that card. But hey, let me tell you, it has so many information, discounts. It sends you letters. They send you newspaper information. So they give you coupons, discounts, whatever the case is. But it's always good. But AARP has designed a specific link for caregiving. And then of course you got the larger there. It's Caregiver Action Network .org at a higher scale nationwide. I'm going to go ahead and stop sharing the screen, and I'm going to go into the caregiver part. And I'm going to go ahead and share. Okay, here it is. Okay, there it is. And this is a link for the UnitedHealthcare link, and it gives you different resources, general resources. It gives you tips, gives you information that you need. But the last page is really the one I want to focus on. It's agencies and organizations that UnitedHealthcare is partnering up with. And this is information from the Caregiving Action Network, very important elder care locators, family care alliance programs, and there's so many things. But very important, one of the unique features that our plan offers our members at no cost is what we call the PERS program. It's the Personal emergency response system. And it's a device, and you've probably seen it very similar on TV, right? Where you press that button and 911 is dispatched. This is a little bit different. This is a personal emergency response, where the key word is emergency, which means that if the individual, does fall and the caregiver can't get the person back up, you press that button, 911 is dispatched at no cost to you. Let's say the patient is alone. The caregiver stepped out real quick to go to the mailbox and they slip and fall. This personal emergency response system comes with a GPS locator, which means that once the individual falls, the GPS will pick up the quick response to it, and then there's a 5-second to a 10-second no movement. Automatically 911 is dispatched to their home. This is in the event that the caregiver is with them and they hear that somebody's breaking into their home, or they hear that somebody's breaking into their car, outside in the Parkway. Again, you press that button, 911 is dispatched to their home. So again, this is something that is unique to the plan. It's a benefit that they can get, for any emergency. Sometimes we've had members where they get locked out of their house or they get locked out of their car, and there's medications in there. They press that button, 911 is dispatched automatically. So again, the key is getting help, getting assistance from organizations, other people, friends, family members, or even neighbors is something that's very, very important. Would you like more information about that? That's where Ashley comes in. You can, set up some time to talk to her individually and talk about the different benefits. Again, I will be sending these links to you, Lynn, and I'll go ahead and send it out so y'all can have those, information. You can keep those, and then maybe you have an internal email where you can distribute to the family, to the friends, or to the caregivers as well. So thank you so much.
All right, thank you so much. It was really helpful. And like I said before, this is being recorded, so all of this will be available, shortly for everybody to have. All right, and I encourage all family caregivers, everybody, to just use these resources, because there's a lot, but every so often just check it out and see, oh, is there something that I might be able to use right now, and it's hard to remember everything all at once, but just to review things periodically, just to keep them, oh yeah, right, I don't have to work as hard because there's some help out there, so thank you so much. That's really very helpful, actually. So, all right, okay, well, does anybody have any questions, comments? And thank you for joining us. I see a couple, or at least one other person joining us. Let me see, I'm trying to reach over here. So anybody have any questions?
I do.
Okay.
I have a couple, three. One thing I'm really curious about is that 10% penalty year over year and the delay in signing up. Can you tell me, which you probably can't, what the original intent of that was, other than being an incentive to sign up? Because to me, I'm sure the people groups that may come into play mostly with are the lower socioeconomic groups who can least afford that penalty. It's because it's quite an excessive amount when that comes into play. Comment.
I think our federal government was designed to keep wealth in the hands of the few instead of the many, and this is just another example of that. So the best thing we can do is try to, get ahead of it and, sign up when you're eligible and not have to pay those penalties.
Well, certainly, but that's, and I didn't, to me, I'm sure that's been in play for a number of years, and that's going way back to the politics of all this. To me, it's just a sad thing, but it is what it is. Okay, number two, I may have missed this.
Can I add something to that?
Sure, go.
Real quickly, just add. Yeah, it's kind of interesting. It's a very good question, and that's something that the government has established through Social Security. The thing is that when many of us, Medicare, Social Security can be very complicated sometimes. and that's why we have representatives like Ashley to come in and kind of at least separate the differences of Medicare Part A, Part B, Part C, and even this question that you have, which is very important. The thing is that once the person once they turn 64 and a half on or about, we have to go and register to Social Security. You can continue working up to 68, 70, whatever, we can continue working. However, we must register. However, this is what the interesting thing is that they send us a book called Medicare and You. I don't know if anybody's received that already through Social Security, right? You go, you register, you do the registration, you get a book about that thick, about 2 inches thick. And for the most part, what we do, with those kind of materials is we just kind of flip through the pages and we don't read it all. Unfortunately, to answer your question more into detail, is that the Social Security representatives don't take the time to sit down with a family member or the family or the husband or wife and talk about those details. And then all of a sudden, when people don't know about that registration and they turn, 66, they stop working, but they never, because they were still had under insurance and they're covered under the group insurance, but then they retire finally and they go into Social Security to claim Medicare. And that's where they get hit with a penalization. And then they come back saying, I wasn't told. And the only answer Social Security is going to say, well, yeah, but you received the material, you should have read it. It's like all of us, right? We have to read those little contracts. But again, that's why we have, representatives throughout the area that can answer and guide and answer those questions, because Medicare, again, is complicated. But our job as representatives, and yes, we represent the UnitedHealthcare plan, right? But our job as representatives is to make those questions easier and help the community when we're out in the field at a health fair or wherever we're at. We try to answer those questions so people don't get hit with those penalties later on down. So I hope that kind of answered a little bit of what concern that you had. So.
Okay, my next question. Again, you kind of touched on this, but with regard to a patient going into a skilled nursing facility, as you mentioned, 0 to 20 days, 0, whatever, and then 21 to 100. But my understanding is it requires a 3-night hospital stay or rehab stay to qualify for that.
I'm not really sure what the question is, honestly.
Well, just verify that there indeed is a requirement of a 3-night acute or rehab hospital stay to qualify for the 0 monthly or the per diem charge for a skilled nursing.
So are you asking, do you need 3 nights in a hospital or rehab before you go into a skilled nursing facility?
To be covered by Medicare.
To cover it. So are you required to be in the hospital for 3 nights in order to get a benefit in or skilled nursing, or can you go into skilled nursing directly from your home and get the coverage by Medicare?
That's a really confusing situation, Horacio. I'm looking through this to try to grab the answer, but maybe you have it right off the top of your head.
Sure. Yeah, the way it goes is that once the doctor automatically signs off and indicates that the patient needs the skilled nursing facility, you've got 2 components. The first component is traditional Medicare, which is the patient, in this case, a family member or the individual is under traditional Medicare. Traditional Medicare, the way the coverage works is that there's Part A, as Ashley covered, and there's the Part B, right? The Part B is for the doctor and the Part A is for the hospital. Now, under hospital, first, if they have only Medicare only, then the family is obviously they're responsible for the deductible at the hospital. Then the doctor says, though, you need to go to the skilled nursing facility, and there kicks in a second deductible that falls into for the family member. Now, with Medicare Part C, which is the Medicare Advantage plans that the government has allowed for individuals to choose, just in our case, through let's say a member comes in, one of our members comes in for skilled nursing facility, it'll be a 0 copay per day for the first 20 days. So there will be no deductible there. However, after on the 21st day, then the family will pay $188 per day, which is going to be less, much less than what they would pay through a traditional Medicare. Now,
Yeah,
if the member,
I'm sorry, I just wanted to add, I'm looking at what Part A would cover with traditional Medicare for the skilled nursing. So days 21 to 100 would be $194.50 a day. So even if that
Yes.
doesn't sound like it's much more, when you're talking times 100, you know, $5 to $10 can
Well,
really
sure.
add up in savings.
oh yeah, yeah. But the key here is to answer the question is, the doctor is the one that it's the primary care physician is going to be the one that is going to make sure that when they refer to a skilled nursing facility, then that has to be in the medical record, and you should be clear to that. So you should be okay.
Well, certainly it'd have to be come through a physician. So you're saying whether or not one's in a hospital or rehab bed or from home, that could indeed occur.
Yes. Yes, that is correct.
Okay. My third comment, I guess, is, I mean, you all work for UnitedHealthcare. I mean, I work in a rehab facility occasionally, and I have the opportunity to interview and talk with patients who are being discharged regarding their medication they're being discharged on. And so I can see, or at least glean information from them as to what type of coverage they may have. You know, and 95% of these patients are on Medicare, okay? And occasionally I come across someone who has no additional whatever coverage for their prescriptions. And to me, that's just a sad thing. And I always wanting to recommend to them to at least examine that, pursue something, because I'm on Medicare, and I have a plan that I'm very happy with, that I pay zero monthly into, you know, for my additional, for my costs. And then I get, my wife and I, we get a number of prescriptions depending on tier at zero copay. So in my mind, many of these patients that I talk with should have a similar coverage. Now, I'm not sure it's within my realm to recommend the one that I have, because that, even though that would be a very good thing for them, or, you know, where could I recommend they call to get unbiased, reliable information on where to go? And of course, you're going to say those numbers that you just presented to me, but you know, because we all get mailings and they follow the year, TV ads and this and that. I don't know.
I'm a little UHC. I want to put this right out there immediately. I'm not employed by UHC. I have a contract with UHC. I'm a non-captive agent, and I can write policies for any insurance company at all.
Who do you
The
work
only
for?
company
Who
I
write-
write for is UHC, though, because they have the best Advantage plans, and that's why. So,
Well, again, that differs based on geography, and I would compare that yours with or that against the one I have, but you know, whatever, we won't go there. So who do you work for?
I work for myself. But UnitedHealthcare has a contract with me, so I can talk to people about plans and write policies.
Okay, so they send you money.
Yes, they do send me money if questions people have result in an enrollment, then I get a commission on the enrollment.
Or if you referred them to a different provider, you would also get
If I wanted to write,
reimbursed by them.
yeah, if I wanted to write policies for another provider, I could. Some people with my agency are working with Humana. I'm not appointed with them because, like I said, where I am in Central Texas, I think UnitedHealthcare has the best offerings. And you know, that's who I want to be with. You know, I don't want to be with a company that's going to
Okay,
do the same.
Yeah, I do have Humana. Again, that's not neither here nor there, but okay. Well, I don't know if you had anywhere in here what your organization's contact information would be. So I guess from what you're saying, that would be or it wouldn't be inappropriate for me to give, say, your number or such a number to this person. You understand what I'm saying?
If I may, Caregiving Cafe is not partial or exclusive to anyone or anything, because our mission is to connect family caregivers to resources. It is up to the caregiver to decide which resource is appropriate to his or her situation.
No,
So,
absolutely.
with all due respect, and I've always mentioned this to all speakers, so hopefully I remember to mention that to you. I talked with everyone, okay, with all resources. I talked to Alzheimer's Association and Alzheimer's Texas, okay. I'm not exclusive, because one resource may be better for one caregiver and a different one for another one. So directly answering your question, Pete, you are free to mention any resource that you have experienced and that you would recommend, because that is in respect and consideration of all family caregivers. I myself had UnitedHealthcare, okay, until I could no longer afford to pay insurance. And I also had Humana, and I've had very good experience with both. My husband, who is on Medicare, has Blue Cross Blue Medicare, because of his very complex situation. He was declared non-insurable. And there are very few plans that would cover his condition, taking 35 pills a day.
Wow.
Okay, and 4 patches and eye drops that cost some of them $50 per eye drop, so we can no longer afford. So, you know, so every situation is different. So by all means, Pete, if you feel in the interest of all family caregivers, you want to mention another resource, I welcome that. And I hope that Horacio and Ashley will understand.
Yes, and that's a very good point. Just real quickly to let you know, we're licensed by the state of Texas. So since we're licensed under the state, we're regulated by Medicare. So this means that whenever when you see us out at a health fair, or even now, for example, we can't chase anybody down. We can't be like an ambulance chaser, as they call them. We have to wait until people come to us, because that's what Medicare wants us to follow the guidelines. So what we do as well, we can't work with a specific doctor. We can't steer to a doctor. We can't steer to a specific provider. You know, when we sit down with a member, we ask them who their doctor is and, you know, what medications they're taking. And if they're part of the plan and they have the network within the network, then it's great. Then if not, we're gonna have to figure other ways. That's why Ashley says many agent brokers have the option to offer multiple different types of plans, because it's not what we need as representatives. It's really what the family member, you know, gives. So when that happens, the second thing that we do is we try to, you know, work with retention. We try to protect the member not to be switched from one plan to another, because it hurts two ways. It hurts, again, it hurts the provider and it hurts the medication. So it means that if they're switched from one plan to another, and that provider is not in the other plan, it hurts the member, because now they got to switch physicians, and it just becomes a snowball effect with their health sometimes. So that's what we try to do: work with the member as much as we can to protect their status, and work with the doctor to making sure that they get the high quality of care that they need. But we can't steer from one person, you know, providers or things like that. But we give options.
I have a question real quick. I know, I just wanted to ask Ashley, if I came a little bit late and I am very interested in what you were reading. I know I read stuff like that, but you reading it made more sense. How can I get a copy of what you were reading?
Okay, you can go to MedicareMadeClear.com. That's right? Let me double check. Let me go to it right now. But yeah, that's UnitedHealthcare has put this together. And again, it's not, as you could tell, it's not a sales pitch. It's an explanation of Medicare benefits.
Yeah, I've had to deal with that with my mom and my dad. And there's a lot of stuff that I don't understand, the part A, the part B, that, and theirs is all free, but still there's stuff that I need to know what they qualify and how better I can assist them. My dad passed 2 years ago, but my mom still alive, and actually right now we're struggling with her. We might put her in hospice. I did not know that they do hospice at home in McAllen and Park, Texas, so that's where she is. So I'm looking into all that right now, and all that information it's really crucial and important to me. Thank you.
No, and welcome for joining us today. I'm glad that you got here. Whenever you can get here, it's always a good time. But I was perhaps setting up a separate conversation with Ashley or Horacio or both afterwards. And I will ask Horacio to please put in his contact information. Perhaps that would be helpful to you, because I agree with you. I read things and I'm like, okay, what do they mean? I think I live on my own planet, my family says so. So, but so that, because I don't speak the language.
And I also,
yeah.
I also work for, I'm actually working at a school, and I deal a lot with parents. I'm a parent support specialist, and I try to get them, what they need with their own family, their own lives, special needs people. And this was really great. I really appreciate you all giving this information.
Yes.
Happy to help you get more information.
Yeah, please feel, they love phone calls. Okay, so I'm speaking for them. So, our objective is to serve and to help. So anything we can do, and I'm sure that Ashley and Horacio feel the same way. So,
Ashley, could you share your contact information, please?
Oh, yeah.
It's on the chat already. I see it.
It's
in the
there
chat.
somewhere.
Ashley is over there. Did Horacio put his in there? Okay, because
I got it.
Yes, I'll plug that in. Yep.
Okay, thank you. All right, I think we might be able to stop the recording at this point, but thank you so much for